How's it from the ED? Chest pain patient arrived. 12-lead ECG was obtained almost immediately. Pain at present 3 out of 10, initially 8 out of 10. Started about 2.5 hours ago. Risk factors for coronary disease in the family. No known risk factors himself, a non-smoker. Sinus rhythm. We then always just scrutinize initially, looking for ST segment elevation in the coronary area, so 2, 3 AVF, 1 and AVL, V1, V2, V3 and V4, and V5 and V6. Just following the right coronary artery LAD or left circumflex pattern. What we saw on this ECG is got ST segment or J-point elevation 3 AVF, 3 more than 2, and what we also notice is reciprocal changes, what we thought, 1 in AVL with J-point depression and ST depression in AVL more than 1. Out of interest, there was ST depression in V2, V3, and V4, V5. And with J-point depression, we then proceeded to do posterior leads. Remember, the posterior chamber of the left ventricle is just hidden from the surface ECG just because of the nature where we place the electrode. So if you change V4 to V5, V6 and put it posteriorly, we get V7, V8 and V9, and their ST segment elevation only needs to be 0.5 millimeters, which you can clearly see the J point that's elevated in V7, V8, V9. The nice little take-home point, whenever you see sort of an RS and the ST's depression in V2, V3, just think about posterior leads as well, because sometimes the ST segment elevation in 2, 3 and AVF might not be that apparent. Yep, patient went to cath lab. And just the other take-home point, whenever you see a J-point elevation or ST segment elevation, always think about the big killers, thoracic aortic dissections, especially in the setting of inferior ST segment elevation, and all the other causes as well.